Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for March 20th, 2019. Thank you for joining our presentation this month. Our presenter today is Rich Waldron, who has spent 30 years as a frontline clinical care physical therapy provider for patients with musculoskeletal issues. Mr. Waldron is the clinic owner of the Knee Joint, Simple Solutions for Knee Problems, catering exclusively to persons with knee and hip pathology and osteoarthritis. He is also the managing director of Joint Academy, which offers a digital program for patients with knee and hip osteoarthritis. Through the Knee Joint and Joint Academy, Mr. Waldron has worked with thousands of patients who have hip or knee osteoarthritis. Today's presentation is titled, A Clinical Program for Osteoarthritis Patients Goes Digital.
Thank you, Osteoarthritis Action Alliance, for allowing me to give this presentation, so I'll jump right into it. First, a quick review of osteoarthritis. If you follow the Alliance, you're pretty familiar with some of these statistics, but I'll quickly review some data about osteoarthritis. 1 in 4 Americans develop hip or knee osteoarthritis at some point in time in their lives. 30 million US citizens are affected by osteoarthritis, according to the World Health Organization. This causes more years lived with disability than diabetes and cardiovascular disease put together. Almost half of Americans at some point in time will have MRI diagnosed osteoarthritis, and the annual medical cost for people with osteoarthritis is about $62 billion. I've seen those numbers higher. I've seen the number of people with osteoarthritis in the 50 million, and I've seen the cost in the $90 billion per year. If you look at the top 5 disease categories for spending for US healthcare, musculoskeletal costs are second to circulatory diseases, third behind ill-defined conditions. According to Blue Cross Blue Shield, their musculoskeletal spend for people under 65 years old, so this is not the Medicare age bracket, they have about a 14% spend in musculoskeletal. And surprisingly, for that age group, the biggest driver of that musculoskeletal cost, or 50% of the cost for the musculoskeletal, is actually coming from total joint replacements, which is the end treatment for someone that has osteoarthritis. So osteoarthritis is a big driver of the musculoskeletal cost, yes, for Medicare, but also for the non-Medicare population. According to the Arthritis Foundation, arthritis is the #1 cause of long-term disability in the United States. There's roughly 172 million workdays are lost annually due to arthritis. And the increase of developing other diseases like heart disease is higher when people have osteoarthritis. Again, the thought being that if you have osteoarthritis, you're not very active. So there's the obesity question, and then there's the comorbidity question. The annual cost for someone that has osteoarthritis is about $10,000 per year. For the Medicare age, so the 65 or older, it's about $13,000 per year, and that's rivaling other disease processes such as cardiovascular and diabetes. The surprising part was the under 65-year-old osteoarthritis cost is also very high. And the biggest driver of osteoarthritis costs is total joint replacements. This is one of my favorite graphs. I actually talked to the people that did this research, and I said, is this speculative? Are you just speculating that joint replacements will go up? And they said, no, this is what's going to happen. And we're actually right at the beginning of the curve. So if you look at the year 2020, you'll see the curve start to go straight up, especially for knee replacements. Hip replacements, not quite as much. And the cost of joint replacements are also going up. So if you put together the increased utilization, the increased cost, this is the biggest driver of the musculoskeletal percentages of cost for the US spend. So we already know from all these leading research organizations, AORC and the American Academy of Orthopedic Surgery, and NICE, I think, is out of the UK. They've all come up with suggestions. They've all looked at the research and said, we know how to treat these people. We know what we should do first. We know what we should do last. So the green triangle are the things we should do first. So the green triangle basically says we should do exercise, education, weight management. That's usually first line defense, going to see a physical therapist or an occupational therapist, getting exercises, getting education, peer-to-peer support. Most or all people should go to that level of defense first. People who do not do well at that level can go on to the orange box. They can leave the green, go on to the orange, and then go into pharmacological, pain relief aids, passive treatments, injections. Very few should actually go into the red triangle, which is surgery. So we already have this established pathway that everyone agrees we should do, including the surgeons, including the medical community. This is agreed upon. AORC guidelines basically says the core treatment should be land-based exercise, weight management, strength training, water-based exercise, and self-management education. So that's one recommendation from AORC. The American Academy of Orthopedic Surgeons say that the high recommendation, they have a very strong recommendation for people to go through neuromuscular education, physical activity, following national guidelines. So these are the surgeons who basically said people shouldn't come to us first, they should go through this conservative care program first. So what happens when someone does follow the appropriate protocol? So this research looked at people who were joint replacement eligible, and they said, what if we put these people in conservative, the green triangle first? If we put these people in conservative care programs first, what would the results look like? And so what they found was 2 out of 3 patients with moderate to severe knee OA eligible for total knee replacement were able to delay their surgery for at least 2 years following non-surgical treatment. So they followed these people for 2 years, and after 2 years, they still didn't feel that knee replacement was necessary. So we put them into a conservative care program. They went through all the recommendations of the green triangle. They went through weight management. They went through education. They went through exercise. And 2 years out, 2 of 3, 67%, didn't get a joint replacement. So the protocol works if it's followed. Unfortunately, we aren't always following recommended guidelines. So PT in Motion and the American Physical Therapy Association did a research of primary care's referral patterns. And they basically asked primary care doctors, what do you do when you come across someone that you think has knee or hip osteoarthritis? What are your recommendations? What are your referrals? Only 34% of the patients were recommended exercise. In other words, only 34% were recommended go to a physical therapy office and get exercise. Only 30% were given education material or sent somewhere where they could learn about their disease. And here's, 60% went to the red triangle. So 60% basically went directly to an orthopedic surgeon's office. So, and this is very difficult because when I've talked to many orthopedic surgeons, when people come to their office, they feel, that they're trained to do joint replacements, they're trained to do surgery, they're trained to do injections. Their MRI or the X-ray will show them imaging that this person has advanced arthritic disease, and their obvious recommendation is going to be one of their procedures. So they've done research on what happens when someone trickles through and ends up going to the red triangle first or the surgeons first. They get a surgery. But this one research said that after going back and looking, a third of those knee replacements were judged to be inappropriate. They were done too soon. They could have gone through a conservative care program. Another research paper said that, okay, people that got a joint replacement, what was their outcome? Were they satisfied? Did they get what they expected out of it? This one said that the people, a high percentage, I think it was maybe 25% of people, had a minimal improvement in the quality of life. So as a clinician, I've had patients come to me and say, I want to go hiking with my hiking club in the Swiss Alps next year, so I'm going to get both of my knees replaced so I can really go for it. Well, that's not the goal. That's not the end result of a joint replacement. You're not going to become bionic by getting a joint replacement. So I usually tell people, get it done once. Get it done when you're really struggling with the basic necessities of life, such as stairs or getting up and down from the bathroom. That's when you get a joint replacement. You don't get a joint replacement because you want to go heli skiing or you want to go hike the Swiss Alps. It's not going to. You're not going to get those results. So then other procedures. So if it's not a joint replacement, you'll see a lot of times arthroscopic procedures. So a recent research paper said arthroscopic procedures should never be used for someone over 45 that has wear and tear in the joint. So they used to do what's called a lavage or a clean out of the joint through an arthroscopic procedure. And the feeling was that's not really helping. It's maybe short term because they'll go in and bathe it with some Marcaine or some cortisone, but that's not helping the situation. As a matter of fact, one research paper I saw said that it triples the probability of a joint replacement. So I always tell my patients, someone going in there and mucking around in your joint and just sweeping it up is actually an irritant to a pristine field. It's an irritant to the joint, and the body responds to that irritant with actually more arthritis, not less arthritis. So the strong recommendation against doing arthroscopic procedures for people that have osteoarthritis. But this research paper from the same year, interestingly, the research paper from October of 17 said we shouldn't do it. Here's one from May of 17 that says it's the most common procedure done for people with osteoarthritis in countries where data is available. So we have this recommendation that says we shouldn't do it. And then, yeah, we have this data that says it's one of the most common procedures done, and it's expediting joint replacement. So the graph that shows that the joint replacement is going straight up. One of the reasons might be we're doing too many doing too many arthroscopic procedures, irritating that pristine field and driving joint replacements up. So did someone try and do it? Did someone actually try and do the right thing? And then what happened when they tried to do the right thing? So in Sweden in 2009, an orthopedic doctor came up with a program called BOA, which is Better Osteoarthritis Care. And he convinced the National Health Service, and he convinced primary cares, and he convinced physical therapists, and he trained physical therapists to come up with a clinical care pathway. So primary care knew, physical therapists were trained in how to intervene, and patients were guided towards BOA before going to the orthopedic surgeons. And this was an orthopedic doctor who came up with this idea. So basically 150, I think it's over 150,000 patients now have gone through BOA. You get in your car, you drive to a clinic somewhere within Sweden. I think there are more than 30 clinics that offer the BOA program. You have a face-to-face meeting with a physical therapist or an occupational therapist-led team. You get exercise instruction. You get education about osteoarthritis. You get peer-to-peer support. When going to the clinic, they collected data. So they would take intake data about your status. They would take periodic data, and I think they collected data after a year as well. So while you're in the clinical session, they're collecting data every time you show up. And after you finish with the clinical session, they're sending information out and getting information back from you. So what was the result of this actual large clinical program? So here's the research paper that said, hey, wait a minute, this actually works. If you take these people and you put them in the green triangle first, it actually works. It's actually very effective. And how effective was it? So they took 22,000 patients and published a paper, and they found that 20% of the patients who came in were taking pain medication at intake, and in a lot of cases, the pain medication were opioids. 20% were no longer taking pain medication. I think it's after 6 weeks. After 1 year, 4% no longer had any osteoarthritis-related symptoms. So they were cured in a sense. They didn't have any problem. They didn't even relate to their knee or hip pain at all. And there was a 30% overall improvement in health. And there's a physical function test, a sit to stand test. So people who come in, we measure how many times they can sit and stand in a minute. And then we keep tracking that information. That's a valid test to determine someone's physical function. And there was a 30% improvement in people's physical function. So what was the effect on downstream medical costs? So if you look back to the graph that I showed for the US joint replacements, it's going straight up in 2020. If you look at the graph in Sweden, after about 4 years of BOA, it went down. Sweden's the only industrialized country that actually had a downward trend in orthopedic utilization for osteoarthritis, which usually relates to joint replacement. Most industrialized countries have the same graph we have, which is going straight up. I think Spain is just like ours. Australia is just like ours. Sweden, because 150 to 200,000 people went through BOA, actually had a downward trend in joint replacements. Interestingly, in Sweden, some counties did not participate in BOA. Their graph went up. Some counties did participate in BOA. Their graph went down. So there was a direct positive effect from using the appropriate protocol in treating these patients. And this is the paper that talked about that. So the published paper on 22,000 people that said some regions didn't do it. They didn't see a downward spike. Some regions did do it. They had a downward trend in joint replacements. So in Sweden, you get in your car, you drive to a facility in the middle of winter, it's cold, it's dark. Maybe you don't want to get in your car and go to a facility. So what if we said, well, since it's just education, it's exercise instruction, it's data collecting, and it's peer-to-peer support, there's not really invasive or things that we do. We don't do any manual things for patients. Is there a way that we could actually not have people get in their cars and we could deliver to them at home? How about a digitized version of BOA? What would a digitized program include? Well, we need a physical therapist to guide the patient. We need the physical activity instruction. We need lessons. We need to educate the patients, and we need to track their progress. But again, these are things that you don't have to go to a clinic to do these things. I can push these things to people's homes if I had the technology. And we do have the technology. So we built, actually the son of the orthopedics doctors built a digital version of BOA. And this is the patient's journey through that digital program. You get an introduction, you meet a physical therapist, you measure your baseline data, you have a physical function test, sit to stand, we get your pain scores. And then as time passes, the physical therapist guides, but also the digital program guides. The digital program can track information. So I can ask you your pain scores on a set program. I can push you exercises on a set program. I can push you education on a set program. You can open up and watch videos about osteoarthritis. So the idea was, could we mirror the same program and get the same results that they got in the clinical version? Well, lo and behold, it actually turned out that it might be a little bit better. So there are 3 published papers about the effectiveness of doing a digital version of the clinical program. And what did we find in the digital version? And this is one of the research papers that said, hey, this actually works. You can actually do the same thing. We can get the same results from a digital program that we got in a clinical program. What did we find from the digital program? So in the clinical version, we had 30% no longer wish to have a joint replacement. Digital program actually beat it. 31% said they no longer wish to have a joint replacement. The main reason people felt they didn't need to have the joint replacement was that education piece. So there were several research papers prior to someone actually proving it that said if you just educate patients, it's called shared decision making. If you give them some ability to have some input, they'll make wise medical decisions. So if they don't know what's going on, if they go to a doctor, the doctor says, here's your x-ray, it looks like you have a advanced osteoarthritis, they don't know what their options are. So when you educate them saying, listen, let's try a conservative program first because people have gotten better using this conservative program, they usually opt for it, and the end results are they turned out well. And there was high patient satisfaction, so they like the flexibility of being able to do the treatment at home, not having to get into their car. I saw a research paper that said it costs US patients about $45 every time we go see a doctor in gas, parking, and lost income. So this is much more convenient to do it I could do it at work and I can do it at home. So here's some more data from the digitally delivered program. After 6 weeks, there was a 21% reduction in pain, and after 20 weeks, there was a 46% reduction in pain. That's not 21% people had pain reduction. On average, people had a 21% pain reduction after 6 weeks. On average, people had a 46% pain reduction after 20 weeks. The physical function test, the sit to stand test, after 6 weeks, there's a 16%. People can sit to stand more. They're more functional. And after 30 weeks, there's 88% increase from baseline on their sit to stand test. Use of medication. So with the clinical program, there's a 20% reduction in medication use, again, usually opioids. We had a 22% reduction in medication use, again, usually opioids, 31% reduction in joint replacement. High adherence, so we can see when patients open their email, we can see when patients interact with the platform. So there was high adherence, there's high compliance, and the NPS score. So patients were very happy to use this platform. They liked it. So typically you get an NPS score in a clinic of about 12. For the digital program, the NPS scores were about 56. And there's one happy patient in Sweden. And now I'll take questions.
Great. Thank you so much for your presentation, Mr. Waldron. I'm going to start with a question, and then we'll wait for others to come into the chat box. If we know the recommendations, so thinking back to the green, orange, and red triangles, if we know the recommendations are exercise, education, and self-management programs, why do you think we are not following the protocol?
I think at the primary care level, so if people go, well, in the US, we can go wherever we want. So we don't have to go to a primary care first. We can go to an orthopedist first if we choose. And so I think the US consumer is used to going where they want. So if we do end up at a primary care office with hip or knee pain, the primary care usually says, it's very difficult for me to triage cardio, derm, osteo, musculoskeletal. So when I get a cardiac problem, I kick it to a cardiologist. And when I get a dermatology problem, I kick it to a dermatologist. And when I get a urology problem and when I get a musculoskeletal, I just kick it to an orthopedic surgeon. And so I think that it's very difficult, and that the primary care is feeling overwhelmed. I think when it gets to the orthopedic surgeon level, it's not that if you give, if you're a hammer, everything's a nail. But I think as an orthopedic surgeon, you want to please that patient. So when the patient took the time, you booked the appointment 3 months ago, had to wait in your lobby, fill out your paperwork, and you come in and say, oh, you don't need anything, go home. The patient feels a little discouraged. So I think the doctor, trying to please the patient, will probably offer an injection at that visit, a cortisone injection or some other injection. Or they'll say, hey, I could do an arthroscopic procedure, or I could do a joint replacement. So I think it's just how we're trained to interact with the patient. Primary care tends to kick to specialists. Specialist wants to do something. They don't want to kick back into the system.
It makes sense. Thank you. Here's another question. Is BOA available in the United States?
Nothing is. So the knee joint clinic we've tried to create a very similar pattern in Northern California, but I wouldn't say there's a standardized organization that's offering, United States-based treatment. No, I wouldn't say there's anything like that. And again, why, I don't know. I can't figure out why. It's because we're so disjointed as a healthcare system. Whereas in Sweden, there's the national health payer, and they're very motivated probably to lower cost. Whereas in the United States, you've got so many players.
And that was another question that came in. Did insurance cover BOA?
Yeah, so the National Health Service, it's a physical therapy-led program. So I think if you just call it physical therapy, but you make it an enhanced program. So yeah, the National Health Service paid for the clinical BOA program. But if you think about the digital version, you don't have to have brick and mortar. I don't have to pay for rent. I don't have to pay for equipment. I don't have to pay for reception. I don't have to pay for utilities. So I can deliver the care cheaper via the technology, much cheaper via the technology than I could via clinics. And it's also more convenient for patients. So patients don't have to get in their car and spend their time. So I think when the National Health Service in Sweden looked at, okay, BOA works, but we can deliver BOA cheaper, let's do that.
In the study that looked at the digital program, did participants know they were being tracked? So do you think that they were more participatory, or they did their exercises because they knew it was being monitored?
Yeah, I think one of the, I'm a physical therapist, and I've been working on a similar platform here in the United States as we tried to ramp it up. And I think, Big Brother is not necessarily watching. It's not that someone's always got eyes on you, but I can see if you've opened up. I can see your adherence. I can see if you've participated, and I can nudge you. So nudge is a big term in healthcare these days. So if someone has not participated, I could say, hey, what's going on? I noticed you haven't opened my emails lately. And usually they'll respond. Clinically, if I give people a handout of exercises and say, go home and do this, I have no idea what they do with my piece of paper. I don't know if they stick it to their refrigerator or if they throw it in the garbage. So this does allow maybe for a little higher level of compliance, because the feeling that someone is there, keeping an eye on you. But I also think it's encouraging, it's coaching, it's health coaching, it's behavioral coaching.
Okay, and I think we have a couple more questions here. Do you think that there are certain movements or types of exercises being done in youth or in middle ages currently that are contributing to higher rates of osteoarthritis?
Well, interesting. I think that the Osteoarthritis Action Alliance poster child used to be a young girl soccer player. So the knee trauma is definitely a predictor. So an ACL, I think it's 3 out of 4 women who have an ACL surgery end up getting a joint replacement or something like that. So knee trauma is probably a big contributor. So if you've had a knee problem, and if you think about the sports, I think that there was a book a while ago called Warrior Girls, and an ACL tear per girl team per year. So I think that's one of the predictors or one of the causes of osteoarthritis. And then the other side might be lack of activity. So there was a research paper that said people who are paralyzed from the waist down, who are in a wheelchair, actually start to show signs of osteoarthritis from lack of use. So the cartilage is not being fed because there's no compression and there's no motion. And I know when the astronauts get back from space, they run the astronauts right into medical, so they don't get to take a break. they go right into medical, and they're showing signs of osteoarthritis from lack of gravity. So I think lack of activity might contribute to osteoarthritis as much as too much activity or running. And I do think that the Running World magazine did a research on people that run more than one marathon a year, and there was no correlation between high mile running and osteoarthritis.
And last question here, how are the exercises in the digital program assigned to patients? Are they customized for each patient?
So it's kind of like, what's the recipe for lasagna? So BOA came up with a standardized care package. So BOA figured out over the course of 150,000 patients what works, what exercise sequence, what education is important. Now, does that mean that somebody else's exercise sequence would not have worked? I don't know that. So BOA sort of set the standard of this is how the exercise should be delivered. And the digital program just takes that same protocol. Now, as a physical therapist, I can modify it. I can make it less hard. I can mix it up a little bit, but I can't make Chinese food. That's my big joke with the physical therapist is you can't come into my Italian restaurant where my grandmother came up with a lasagna recipe and start making Chinese food. It's not going to sell. So we already know a pathway. We know an exercise pathway. But there is some modification that can happen at the physical therapist level, and the patient can actually modify. The patient can say that was too hard, that made my knee sore. The machine's going to listen to that and say, I'm going to make it less hard next time. So we know which exercises are included, mostly strengthening exercises, and we know the sequence of those strengthening exercises, but it's not set in stone.
Well, that was our final question. Mr. Waldron, thank you so much for your interesting presentation today, and thank you for everyone for joining us. That concludes our presentation, but we hope you'll join us next month on April 17th when our presenter will be Dr. Carol Otis of Arcadia University presenting Doesn't Everyone Get the Same Thing? Learning what total knee replacement post-operative physical therapy looks like.